Thanks everybody for joining us. We got a ton of great questions, so we will not get to all of them. I apologize in advance for that, and we will probably group a lot of questions because a lot of them had the same themes, two things, so they'll probably be wrapped up to some extent as much as we kind of can.
How about I start with some of these, Perfect. The index cards, since you guys are here. I got one that asks, what age is considered older in terms of onset? And that's definitely a challenging question to answer, and I think older depends on how old I am. And so I think for some of the studies, it's not well elucidated. We think about aging as it relates to kind of biologically, really when someone hits the ripe old age of 30. So it's not quite, older is not necessarily quite old. And so in some of the studies that they look at, some of them define older as over 50, some of them define it as over 65. So there's not really a great universal definition in terms of considering what is older comparative to onset. And then the second question on this card is explain what neurofilament light chains are, and I absolutely can. It's something that you'll probably see more and more gaining a little bit of traction, but again, I still don't think we properly know what to do with it. It's something that's called a biomarker. So a biomarker is essentially a way of saying, here's a blood test I can use as a surrogate for how something else is doing. So thinking about if I check neurofilament light chains in the blood work, essentially as a surrogate for how nerve health is. So that's kind of something that we see. We also see a lot in the studies right now about something called GFAP, which is a biomarker for how astrocytes are doing. And again, I don't know that we've really reached a point where we go, I can use this clinically. There's some thoughts that neurofilament light chain increases when you're actively having a relapse or right before you're gonna have a relapse. But ideally, I mean, I think the way we like to operate is that people aren't having relapses at all.
Yeah, I mean, to give one example around neurofilament light, we looked at neurofilament light in a study that switched people from rituximab to Ocrevus a number of years ago. And it turns out that we were really good at predicting all the small people in the trial. Most people tend to have a brain that's about the same size, doesn't vary much, but our body sizes change a lot. And so as that neurofilament light chain, when you're stable, makes it to blood. If you're bigger, you have more blood, you dilute it out more, right? So it's a more of a dilutional factor, right? So you have to adjust for certain things. We know we have to adjust it for age. As patients get older, you have to adjust for that because levels go up. And then you also have to adjust it by weight, because that influences those levels some. So coming in with a level for any of these markers a lot of times is straightforward. For these, it's not. And some of the places that do the testing will adjust for some of those factors. And I think I just heard of the first lab that's actually adjusting for both of those factors. But I haven't confirmed that yet. So I think it's one of the things that there's a little bit more to learn about that. Yeah, let's talk a little bit about PIRA and progression, and I think there's a lot of different topics that kind of fall under this topic. PIRA is progression independent of relapse activity. So people getting worse without relapses. I think I'll take a step back and kind of just talk about terminology a little bit. On high efficacy therapies, a lot of the clinical events that we treat are not associated with the inflammation that we tend to associate with the MRI measures, for example, either. So there's different terms for some of these things. I get a little bit more specific. The other term that's sometimes used is PIRMA, which progression independent of relapse and MRI activity. That's probably a little bit more consistent measure with what we might think about in our clinic, because again, our drugs tend to be so good at taking care of those MRI lesions. So for some reason, I'm not sure why it became such a popular topic, because I think to some extent for people living with MS, PIRA was just progression. And that's just a term from a trial perspective to mean progression. And I think the reality sometimes started to come in because in relapsing trials, it became surprising when they started to see progression, which I'm not sure that we're that surprised by. And we would have said that, yes, a certain number of patients that we think would be relapsing to begin with would go on to develop progression at some point in those trials. So these are terms to measure progression. As far as I would interpret this, I don't know that I would separate it out. How you define it becomes a definitional thing, but it's just trying to measure some of these things. There's progression and there's worsening. Progression being stuff related to MS, and then there's worsening. In the past, when I presented these slides on confirmed disability progression, it would be CDP, but you notice that there's been a shift to calling it CDW, confirmed disability worsening. And to answer a lot of the questions that got put in, it's really hard to separate what's MS related and what isn't. So the worsening component is probably a little bit of a better term, which encompasses many different things. And so I don't know if do you agree with most of those concepts?
I think one of the things that you will find is that we're seeing a lot more of the circulating PIRA idea, which I agree, I don't think is something new or novel, but it's really hard because in different trials, they use different definitions of PIRA, which also makes it complicated. And I think if you put 10 MS specialists in a room, heck, if you probably put all of us in our group in a room, we probably all wouldn't agree on a definition of PIRA. So I think that also makes it a little bit complicated. But I think one of the things that cannot be overemphasize is what is the impact of aging and kind of how that relates to worsening in MS, because we know that things change as people age. And I think it's really hard to separate the two from each other. And I think one of the things that becomes incredibly relevant is making sure that we're not accounting something to MS when there's another identifiable cause. And one of the most common things that we talk about is things like deconditioning. So it doesn't take any time at all to lose muscle mass, whether you're in your 30s or you're in your 70s. It takes very little time to lose that. And so, of course, if you have MS and you're deconditioned because you're not able to use those muscles as well, that weakness is going to become more pronounced. And so I think that's one of the things that becomes really important, especially as you guys have discussions with your physicians, to say, well, what are things that I can tangibly do something about? Because we've seen some of the progression data, and there's not a magic bullet for that quite yet.
So one of my collaborators, Stephen Krieger, will often use the example of when we're talking about these pseudo-exacerbations and how, pseudo-exacerbations by definition are things that are not driven by MS, but can cause MS symptoms to come up. They raise body temperature, they make you feel yucky, so you're not going to have the same energy level. If you don't have that same energy level, you're not going to walk as far and things like this. So it could affect the measures that we use to define a relapse. In the past, we would have said a lot of times this should return to baseline or get back to normal. But I think we have enough experience, for example, and the example he used was COVID, right? So if you get COVID and you have a bad enough case of COVID and you start requiring oxygen, right? You had enough damage to your lungs, you're probably not going to walk as far, as fast, and have a lot more fatigable type of symptoms that are going to get reflected in our scales that we use for MS. And so it wasn't necessarily that it was driven by MS, but it also means that it's probably not going to recover maybe 100% within a month or 2 months or something like this. It's probably going to take a lot longer for those lungs to heal up and things like this. And then if you're in an ICU intubated for a month or two because of the COVID, right, then to kind of bring up the example like Anna did about, the deconditioning that happens with that, it's going to take a long time to potentially get back to where you were at before. So it would be awesome to be able to separate sort of all of these different components, but I wanted to kind of highlight a little bit about the bleed through around some of these definitions, because I think some of the confusion that you'll see between trials when we're using some of these terms is just a little bit talking about sort of the gray zones of MS and trying to kind of come up with measures to design a trial so that you can look at those outcomes and see, how do we measure this versus how do we measure that? And the trials are trying to do as good as they can, but it makes it really hard to do this.
And the last thing I'll say on this topic is I would almost use it as a point of optimism, because I think there's a lot of, well, is this progression happening and do I have no control over it? And that feels quite hopeless and I think daunting. And I think the thing that's really important to emphasize, or the thing to take away from this, is I think there's just so many things that contribute and so many things I think that we do have control over and things that we can use to kind of shape how we do going forward. It's not 100%, but it sure is a heck of a lot in terms of daily quality of life.
The term that's getting thrown around a lot, and we were just talking about different types of inflammation, is smoldering inflammation. It sounds great. I think it fits well for what we're trying to describe. I think one of the things is, from a practical perspective, is what does that mean? And the answer is we really don't know what that means. So what it has been associated with in the trials is trying to kind of look at some of these new markers that we're looking at, these paramagnetic rim lesions, the slowly evolving lesions. So these are lesions that are kind of slowly growing over time. The problem is that for trials, slowly evolving lesions change volume over years. So if you're trying to do a study, over 2 years, trying to see a change or a less change of growth of these lesions over a year or two is really hard to do. If you have 5 years to do those trials, then that's where you see those changes in that part of the biology that's within MS. For paramagnetic rim lesions, it's the same thing. Those lesions tend to happen at the very beginning after a big inflammatory lesion. That's when they form. But we tend to see progression more towards older patients and patients that maybe can't compensate as well or things like this. So to take and say, oh, pearls are associated with progression is hard because they tend to be associated more with relapses early than they tend to be associated with progression later in the disease. But they tend to be with worse lesions, so patients that are having more inflammation to begin with do tend to have more progression. So we can see, for example, that the part that's associated with pearls, right, does go some with progression, but it's not like 100% overlap in the patients that would tend to see those lesions in. Pearls also live 5 to 10 years. So if a lesion is there, does the going away mean that the drug worked, or is it that it's taking that lesion away? Like it didn't form more pearls. So those are questions that, again, because these things happen over years, right, we're going to need trials that really kind of extend out for years. And the techniques for looking at pearls, for example, we don't do that in clinical practice. We can overlap and kind of put side by side some images and things like this, but it's not part of our standard sequence for our neuroradiologist now to say, hey, how many pearls does this patient have? Okay, so we're going to have to kind of work with them to kind of get them incorporated, and we're doing that. But there's been a lot of changes, so there's a lot of work still going in and trying to kind of measure these things and try to understand how to measure that. And the inflammation associated with all these different pathologies is probably different. And that's a little bit of why we got excited with the BTK inhibitors, because they work on a couple of different parts of the pathology, at least as much as we think that it might.
And I might shift gears a little bit to some of these other questions. I think there were a couple of questions about telomeres and how close are we to using them as a measure of progression or as treatment, and how do we measure them? So they're not clinically available, so they can be done as a blood test. The nice part with telomere studies is there's a lot of interest in them, not just in MS, but in a lot of different conditions, because I kind of illustrated how many conditions that affects. There's some really basic early studies looking at them in terms of how they relate to MS. And so I think it's something that we'll kind of start seeing a lot more of coming forward, but there's not necessarily a good way of saying, well, yours measures exactly this length, and this length is what I would use as a predictive model, because I don't know that we have enough data to use it in a predictive manner quite yet. But I am really optimistic that that is something that is coming, because I think there's a lot of interest in looking at this as a marker, not only for disability, but for biological age in multiple disease sets.
The other cluster of questions that we got was related to remyelination. I think this is sort of this improvement quality that we're very excited about. I maybe to dispel a myth and kind of saying there's a lot of work happening in remyelination. The fact that we're not seeing things come out to remyelinate, I don't think is a function of conspiracy theories or anything else like that. But just the fact that it's been hard to find targets for this. We have had multiple drugs go through at least phase 2 and 3 trials looking at trying to remyelinate things. One of the challenges that we're having is that in order to remyelinate, it implies that the nerves are still there. And that has been, I think, something that from a biology perspective is hard to measure. And understanding that a nerve is there but missing its insulation or the myelin, and how many patients that might exist in. One of the clues that we can see that in is how many people respond to Ampyra or dalfampridine. So this is a medicine that makes signals go through areas that have lost their myelin a little bit better. And we normally say that it helps maybe about a third of the patients that we see. So if in a trial you include everybody without looking at things like this, you're trying to maybe improve a third of patients that might be improvable, and it's going to create, again, a lot of noise for trying to improve things. Some of the work implies that it's not going to be just a matter of getting signals to allow that remyelination to happen, but then that you need to have the feedback from the nerves to get those oligodendrocytes, which are the cells that make the myelin, actually get activated to do that. And so it's going to be sort of like a two-step therapy improvement, where you're going to need something that allows those oligodendrocytes to kind of wake up, and then something that teaches them to do what they need to do, which is probably going to be through things like activity or activating those nerves, which usually means exercise, but that only works for certain nerves, right? If they're involved with vision, you're going to have to work the visual pathways. If you're trying to improve hearing, you're going to have to work on hearing type of activities, balance, all the different domains that are involved with MS. And so you're going to have to do a lot of kind of rehab type stuff to kind of get those signals to do better. And so the rehab piece is important, the remyelinating piece is important, but it's probably really the combination of those two in some of those patients that have the potential to still kind of see some of that improvement. So I think there's improvements, there's a lot of things that are being looked at, but just to kind of highlight that we're still trying to figure out how to do those trials, I think, better, and it's going to require a little bit of a change in how we think about selecting patients for those studies.
And I think the other thing that we're slowly making progress on too is learning how to study it better. So for example, some of those oligodendrocytes, those cells that stimulate or that create the myelin production, are stimulated in areas of different densities, meaning how hard or soft a surface is. So a lot of our studies start off in Petri dishes, and that's not just unique to MS, but a Petri dish is a very hard plastic surface, and the brain is actually a very squishy surface. So really creating environments that simulate the brain better allows us to have better translational luck when we're going from Petri dishes to human subjects. And I think that was something that had been underestimated until recently. So making advances in how to study it better, I think also gives us better chances in terms of translational positivity. I got a couple of other questions just about the comorbidity piece as it relates to MS. And so one of the questions asked something about if I've got diabetes and hypertension due to obesity with MS due to mobility issues, I mean, how do you go about that? And that's one of the things that becomes really quite hard as you go, I end up in this never-ending cycle where I can't move, therefore my weight gets worse, which then makes my comorbidities like high blood pressure, high cholesterol, diabetes worse, which then makes my MS worse, and it just keeps going around. And this is one of the things I would emphasize, as there is definitely exercise for everybody, regardless of conditions. So one of the things that's been helpful, I think, one of the things I think is really helpful for most patients, if you were able to access it, is water therapy. The nice part with water therapy is if you've got arthritis conditions, if you've got a bad back, if you're prone to falling, guess what? You're not as worried about all of those things in the water. So water exercise is fantastic because you eliminate gravity. You use the buoyancy of water to be able to do more activities than you normally could. So even if it's just as simple as water walking, gosh, that is a fantastic activity for those that have limited mobility due to MS, or if you've got MS and arthritis, or MS and any of these other things. I think the other thing that's really great is a plug for Michelle Harrison's online Zoom classes. They are twice a week, I think, Tuesdays and Fridays, but I could be making that up. Okay.
That's right.
Okay. And it's nice because everything's from a seated position. So there's a ton of exercises you can do from a seated position. You don't need to be up on a treadmill, on a bike. In order for something to qualify as exercise, I would venture a guess that there is a ton you can do from a seated position that'll make you out of breath, which means I'm doing the right thing. I'm actually doing cardiovascular exercise. And to add to Dr. Alvarez's last point about remyelination, we know one of the greatest things that's preventative against brain atrophy or brain shrinking is that cardiovascular exercise. So increasing heart rate, again, something that feels like you're working. If you go, I'm exercising, but I'm still able to have a really great conversation, that's probably not good exercise. But we know cardiovascular activity increases connections of the brain from one part to another part, and is really one of the strongest and really the only thing we have against aging in everybody.
We also had, alluded to the questions around sort of trying to distinguish what symptoms are MS versus not MS. And one of the big questions was bladder, for example. And the question there is, we work with our colleagues a lot to try and sort that out. Sometimes it's MS and sometimes it's not. If you're, one of the common reasons for seeing retention, especially in MS after a while, is prostate, enlarged prostates. Things like this where there's, we kind of sometimes forget about getting some of these other things checked out. But that's part of the reason for working in sort of big multidisciplinary groups. If you have new symptoms, ask us about it. We might shrug our shoulders. I do this at least once a day when I'm in clinic, saying, I have no idea, I've never heard of that happening, weird rashes or things like this. Is it drug related? Maybe, maybe not. Sometimes we might try to, there's things we can look for, or there's people that we can kind of send you to that can kind of sort out some of those things. But if you don't bring it up, it might lead to things like it's just an enlarged prostate and we got to deal with that and it's fixable, or we could start this other drug and I can kind of work with that. So don't expect an answer would be my answer, but if you don't ask, you also won't find out.
And I think the other thing too with bladder issues, because I think there was a question as well about this, we typically associate spinal cord lesions with bladder issues. Now you could, in theory, have a brain lesion that causes bladder issues. It's just a lot less common because there's a lot of redundancy in the pathways in the brain, but usually thinking about spinal cord lesions as something where we would expect bladder issues to come from. Now, bladder issues in MS can vary quite a bit, so there's not one size fits all. So things like urgency, like I need to go to the bathroom now, can be one of those examples. Another one can be incontinence, where I can't hold it. Another one could be, I felt like I needed to urinate. I went to the bathroom and I just didn't empty, and then 5 minutes later I really had to go. So that's incomplete emptying. And we can see any of those three or some combination of all of those three in MS. I think the other thing that I would emphasize in addition to kind of the The prostate enlargement is in most women if you've had children or pregnancy, or if you're perimenopausal or postmenopausal. There's a lot of pelvic floor weakening. So sometimes pelvic floor physical therapy can be incredibly helpful because it's one of those things that can make MS symptoms look more pronounced. So strengthening that pelvic floor, I think for men and women, can be helpful as well.
The other one that kind of came up a little bit was around back spasms and back pain. Trying to sort out some of these things does sometimes require getting that fourth spine MRI, the lumbar spine, and kind of checking for some of these things. A lot of times you can get back spasms, which, secondarily are often related to MS or other conditions. If you're not working out your lower back as much, the difference in the low back for patients that see me and say is like, if I'm slouching like this, I'm not using my back. If all of a sudden I go like this a little bit, like that back now is fully activated and it's completely getting a marathon. If you're over the sink doing dishes, chopping, prepping food, for a couple of hours, it just got a 2-hour workout. And so thinking about the muscles and what gets affected becomes really important. So again, I think talk to your docs and kind of evaluate sort of who best to talk about it is also, a great strategy.
The next question I've got on here is about the menstrual cycle in relation to MS symptoms. This is something that we have seen really well established. We know with all the hormonal changes that happen with the menstrual cycle, when there is a decrease in estrogen and progesterone levels, particularly in the days leading up to when a woman has menses, we actually see kind of, as Dr. Alvarez was alluding to earlier, the pseudo-exacerbation or pseudo-worsening of symptoms, where people might say, I have more fatigue, my leg feels weaker, maybe my spasticity is weaker, maybe I've got more cognitive issues or brain fogginess. And it tends to be very cyclical. So it's something that I often will ask patients to pay attention to. If you're saying, gosh, I have a couple days a month of this intermittent fatigue or of worsening X, Y, or Z MS symptoms, we often see a relationship with that hormonal shift. Things that can help with that, oral contraceptives or any sort of hormonal regulation where you're getting more of an even keel rather than that drastic dropping off, can sometimes help with that. Not all patients are good candidates for hormonal contraceptives or tolerate it well. The other thing that can sometimes help is using symptomatic therapy. So I have a few patients that say my fatigue gets really bad. So we go, here's an anti-fatigue agent, use it in the days leading up to it. And sometimes using symptomatic medicines in that period can be helpful, or sometimes even a daily aspirin or Tylenol around that time. We think some of that worsening might have to do with the increase in body temperature that happens with menstrual cycles. So sometimes even taking like a daily baby aspirin around the time that you're expecting your menstrual cycle. I also have some patients that do it around ovulation, can really help mitigate those symptoms.
There's another cluster of questions around sort of stopping or de-escalating therapies and how to do that. I'm 55, I'm 60, I'm 65. I'll stop there. I don't have the answers for how to do that. There's no cutoffs, right? I think it's very different to look at somebody who was diagnosed at age 10 versus somebody like Friday, we diagnosed somebody at age 78 that had a new brain lesion, that led to an MRI for a diagnosis of MS, right? These are extreme examples. They're probably in the 1% to 2% as far as age ranges, but they happen and we see this all the time. So when we throw out a number around age 60 is when relapses stop, we're talking about the bell-shaped curve that happens for all of our patients and kind of trying to kind of say, this is maybe a talking point, a starting point, right? Then you have to go to the individual person and kind of say like, for you, you're for just this instance, maybe average. And so you could fit into the average statistics that we use, or you might be in the earlier phase or older phase, so looking at how stable you have been and those kinds of things becomes very important. The trials around stopping drug have mostly come off of kind of our weaker drugs, the older drugs that we've had, people that were on the platform medicines for 20 years plus, can I stop them down? And as you saw from some of those trials, they did okay. The DISCO MS study that Dr. Corboy ran here looked at least being 55 stable for 3 to 5 years minimums. And if the average age of the person was in the high 50s, they did really well in being able to stop drug. The European trial had an average age in the high 40s. That did not go so well. So that study had to be stopped. So if you're on a B-cell depleting therapy, a Tisabri, bigger guns, even some of the orals, there wasn't a lot of patients on those medicines in those trials. So those need to be kind of evaluated, and that's a little bit where we're looking at de-escalating therapies, kind of taking step downs versus just kind of all of a sudden stopping off. And we have some of those trials going on, and we're trying to kind of see what experience it is. I'll take 2 seconds because I'm going overboard, but I think the important balance for treatment is to look at the side effects of those drugs. So it's less about that the drugs don't work. If their drugs were safe, we would continue them later on in life, right? But those big gun drugs that most of our patients are on now do have higher risk of infection. There's other things that are higher on that list of being associated with infection. Level of disability. If you're in a wheelchair, the chances of not doing well from an infection perspective are much higher than if you're walking and talking and doing well. So when you're starting to think about this, I think it becomes important to look at all of those things. What are your antibody levels? If you're on a B-cell depleting therapy and your antibody levels have gone down a lot, we should probably think about ways to try and reduce that risk of infections. If your antibody levels are holding, you're walking and talking, and you're 70 years old and doing well, I think it's sometimes reasonable to kind of continue some of those drugs. But it's that trying to kind of put all those things together that becomes a big challenge.
And I think that's an excellent recap, but I think the other thing I would maybe add to that is also remembering that some of our medications can cause more disease activity as you come off of them. So we think about natalizumab or Tisabri as being one of those, some of the oral medications. And so really thinking about, and I think we do this quite often, is kind of thinking about, well, here's the plan for the next year, but also what is our long-term plan? What's our 5-10-year plan? And just remembering that a lot of these medications, when we think about some of these trials, we are often taking a very select, cherry-picked group of individuals in these trials and trying to apply it broadly. So if we look at some of these progressive trials, looking at some of the medications like Ocrevus, very select group of patients in their 40s, and we're trying to apply it to people in their 60s and 70s. And so just remembering that a lot of this is not necessarily always one size fits all, because I think there's something that might be a really great option for one patient that's not so great for others. So remembering that too, because we want to make sure that benefits are always greater than risks, as Dr. Alvarez alluded to. Perhaps the next question I'll answer is one of my index card questions. Sorry, just kidding. No. We're at 0 minutes. Never mind.
Well, yeah, we'll call it off there. Break now?